Welcome to another season of the ASTIT podcast, where we turn science into sense. In this season, we are introducing you, our listeners, to some of the Justice Community Opioid Innovation Network, or JCOIN, family. In episodes 1 and 10, you will hear from our funder, the National Institute on Drug Abuse. And in episodes 2 through 9, you will learn about cutting-edge and recent science published by some of the investigators working in the Learning to Advance Practice, or LEAP, program, a part of JCOIN. This is so exciting. So let's get started. I'm Danielle Rudes, your host, and this is ASTIT. An important topic for today. We are going to begin the conversation on a complex but critical issue: how clinics handle urine drug screening in their effort to tackle treatment for opioid use disorder. I will say it one more time just to make sure you heard me right. Opioid addiction is a significant public health crisis in the United States. Thankfully, treatment options like methadone clinics exist. These facilities provide medication to manage cravings and withdrawal symptoms, offering a pathway toward recovery. The challenge: many patients don't stay in treatment long enough for it to be effective. Researchers like Price, Michener, and colleagues are investigating why this happens. We are going to explore their study examining how urine drug screening, or UDS, practices in methadone clinics might be impacting patient retention rates. Think of retention as how long someone in treatment stays in treatment. Ideally, patients stay long enough to truly stabilize and develop healthy coping mechanisms. However, many leave prematurely, hindering treatment success. Urine drug screening is a common practice in methadone clinics. It checks if patients are using other drugs besides methadone. The goal is to monitor progress and potentially prevent relapse. However, Michener and colleagues suggest that these tests might be driving people away from treatment. In 2024, these researchers analyzed data from methadone clinics across the U.S. They compared clinics heavily reliant on urine drug screening, where patients are chosen for testing by chance, or observed urine drug screening, where someone watches you provide the sample, with clinics that used urine drug screening less frequently. The results were striking. Clinics with more frequent, random, or observed UDS had lower patient retention rates. So, what does this mean for opioid treatment programs? The findings suggest that the modality of UDS, urine drug screening, can significantly impact the long-term retention rates of clients in treatment. High utilization of potentially stigmatizing practices like random and observed UDS might deter clients from staying in the program, which is counterproductive to the goals of these treatments. Michener and colleagues' study highlights the need for more person-centered approaches in opioid treatment programs. What they mean by person-centered is that the program focuses more on the person going through the treatment and their needs, for example, as opposed to the simplicity of having someone else regulate the individual. Federal guidelines already recommend that these programs make every effort to retain patients and only use administrative discharge as a last resort. To be clear, patients can both voluntarily leave the program and be kicked out of the program due to administrative discharge. However, the discretion given to these programs in how they conduct urinary drug screens and manage positive results could be contributing to lower retention rates. These findings raise questions about the impact of urine drug screen practices. It is important, after all, not to forget the human element. UDS violates a person's privacy, is embarrassing for an individual to have to go through, especially if they're being observed during the process, and it's stigmatizing because the person is being treated as if they have done something wrong, even if they have not. The stigma and punitive measures associated with UDS can erode trust between clients and providers. As one former participant shared in this study, the fear of not being able to provide a urine sample on request led them to leave treatment and return to heroin use almost immediately. This personal account underscores the importance of reevaluating how opioid treatment programs handle drug screening and the overall treatment environment they create. Policies and practices that reduce stigma and support client retention are crucial for improving outcomes in opioid use disorder treatments. Another article written by Michael Inks from 2021 entitled Reassessing the Role of Routine Urine Drug Screening in Opioid Use Disorder Treatment provides additional personal perspective on the use of routine UDS in treating opioid use disorder. Inks recounts an experience with a patient who was subjected to a routine urinary drug screen during a medical visit, which showed a false positive result for heroin use. This incident caused significant anxiety and mistrust in the patient-provider relationship, a similar situation to the one Michener and colleagues provided. Inks goes on to highlight several challenges with routine UDS, including the high cost, the potential for false positive results, and the lack of clear guidelines on how to respond to unexpected test results. Inks emphasizes that routine UDS can reinforce a power dynamic that places the patient in a subordinate position to the provider, akin to the experience many have had in the criminal legal system. Despite these challenges, Inks acknowledges that UDS can play an important role in a multi-domain approach to opioid use disorder treatment. However, Inks, just as Michener and colleagues, argues for the need to develop and adopt more patient-centered assessments. Circling back to the focus of this episode, the study by Michener and colleagues provides critical insights into how UDS practices can impact long-term retention in methadone treatment programs. It calls for a shift toward more supportive, person-centered care approaches that prioritize retention and reduce stigmatizing experiences for clients, a call that seems to be echoed across the current research. After all, we must always remember that these people we often hear referred to as addicts, druggies, and users are in fact people. Substance use disorder is a disease, one we should treat, and that treatment includes how we treat the people experiencing it. Helping should not ever include belittling, ostracizing, or making someone feel uncomfortable or anxious. Helping is supportive and caring. Let's focus on that as we work to help people with substance use disorder and opioid use disorder. They deserve, after all, the very best we have to give. Thank you for listening to the ASTIT podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write me, Danielle Rudes, at Sam Houston State University. My email is drudes@shsu.edu. And of course, thank you to the Justice Community Opioid Innovation Network, JCOIN, their Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters on this season, Sam Houston State University doctoral students Alexa Mata and Bryce Kushmerek-McCune. And a huge and heartfelt thank you to Jason Luchin and the team at Slonky LLC for their amazing production. Tune in again soon for another episode of ASTIT.